So our next speaker today is our own Adam Levy. He's the Director of Pediatric Neuro-oncology at the Children's Hospital at Montefiore. His clinical interests focus on brain tumors and particularly new drugs and treatment plans for children with brain tumors. He's Associate Professor of Clinical Pediatrics here at Einstein, and he's the Director of Pediatric Hematology Oncology Fellowship Training Program. And looking forward to hearing about care of TSC from the perspective of an oncologist.
So thank you so much for having me, Dr. Walkley. Thanks for inviting me. And everyone's telling Dr. Rapin anecdotes. So mine is unrelated to the hospital. Around 10 years ago, I went to lease a car. And when I filled out the application, I wrote that I work at Montefiore. And the owner of the car dealership got teary-eyed and said, Dr. Rapin was my kid's neurologist. He's now all grown up and so healthy. And her effusive appreciation was really poignant to me as a clinician. I don't think it affected the deal I got on the car. But it was really glorious to see the impact that Dr. Rapin made on this family so many years later. So it's really an honor to speak at a conference with your name on it. We heard from some, international leaders in this discipline. I'm just going to give a clinician's perspective and more specifically a pediatric oncologist perspective on tuberous sclerosis complex and kind of the things that folks come to me with these concerns. And I'm just going to start with a history going all the way back. I used to hate history in medicine when I was a trainee, but as I get more senior, it's more interesting how things evolve, and especially over the last 20 years, how this has evolved as a clinician is so impressive. So in 1862, von Recklinghausen first described a baby that died just after a few breaths, and on autopsy was found to have cardiac myomata, as he described, which is actually really surprising because most kids with this heart issues and TSC do totally fine. But he described the first baby with the syndrome based on that, and also noted that the brain of that baby had numerous sclerotic areas. And then in 1880, Bournville further described the neurological findings and coined this phrase, which I'm not going to attempt in my high school French, but first coined tuberous sclerosis. And he noted the facial angiofibromas in some patients, but didn't really make that a formal linkage. And then later, with another colleague, described some of the renal tumors. And this is from one of his papers looking at some of the tubers that they found in the brain. In 1885, the genetic link of the disease was noted by a mother and a daughter who had the sebaceous lesions on the face. And then over time, we see the ungual fibromas that Fatima mentioned and retinal lesions were described. And then in 1908, there was a triad described of epilepsy, and I've changed this because I'm politically correct, to cognitive challenges in these patients and the adenoma sebaceum. And it wasn't until 1932 that the ash leaf spots were kind of formally recognized as part of the syndrome, even though they're so prevalent. So I said I'm going to talk as an oncologist, so when do folks call me as a pediatric oncologist with these concerns with these patients? And there are mainly three domains. Those are the heart issues, the renal issues, and what I do most of my time with Fatima in our neuro-oncology clinic, shameless plug, the brain tumors. So first with the primary cardiac tumors in infancy, these are incredibly rare events. This is a very new manuscript. It's available online but not yet published in print, looking at a series of around 50, almost 50 kids with primary cardiac tumors in infancy and childhood. And what we see here is that 13 of them are the rhabdomyomas that are associated with tuberous sclerosis. And most of the time, these do not require surgical intervention. And management as an oncologist is really never an issue other than helping to think of what's the differential diagnosis. I have actually had patients who had rhabdomyosarcoma in infancy and teratoma. Personally, I've been involved with some of those patients. So I think our role in this regard is to really help rule out what else could this be, and is this an oncologic issue that needs our intervention or not. The cardiac lesions in tuberous sclerosis occur in around 2/3 of newborns with tuberous sclerosis, and they'll have at least one lesion, but can have multiple of these lesions throughout the heart. Usually these are asymptomatic, and they typically shrink over time. And really our role is reassurance and making sure that the cardiologists are involved and that there's no outflow obstruction and that there's no concern from a cardiologist perspective. And these can be followed with echocardiography, and as long as their cardiac function is okay, don't require much intervention at all. The renal lesions in TSC are another issue that as an oncologist I get called about. And actually, Dr. Davinsky, when I was newly minted attending at NYU around 12, 15 years ago, called me for one of his patients with TS and said, I have this kid with, really big kidney lesions, do something. And I was like, okay, I'll make something up. And it was really pre-mTOR inhibitors being utilized. And at the time, really was just surgery or observation. So these are some of the lesions that we see in TS, some of the renal lesions. And they are troublesome because they can form a bleed. So if you see this is the kidney with those lesions, this rind here is actually a hemorrhage into the renal capsular. So some of the complications that can be resulting from these lesions. And up to 3/4 of patients with tuberous sclerosis by 10 years of age can develop these renal angiomyolipomas, which are really poorly named from an oncologist perspective because AML to us usually means acute myeloid leukemia, but in this setting it's angiomyolipoma. Multiple tumors are really typical. Again, they're generally asymptomatic, but they can bleed into the kidney and they can bleed into the urine. They can cause mass effect, which can cause pain and tenderness, and they can infect the renal vasculature such to cause hypertension. A small but real measurable percentage can transform and lead to carcinomas, and that's, again, a concern for us as oncologists to decide when is this an issue worthy of intervention. The imaging is usually pretty clear with when these are just AMLs versus when they can be a carcinoma, but if they're a fat poor lesion or other imaging changes can make it concerning. And we're in particular concerned about the lesions that are growing rapidly. So how are these managed? Again, usually we just watch and see historically, and for acute hemorrhage you can embolize these and then give some steroids. The larger lesions might need surgery, or if there's concern about transformation, a biopsy. And then, of course, recently, and you're going to hear from other speakers, and as we have, the use of mTOR inhibitors for asymptomatic and growing AMLs. And we have a number of patients through Fatima's clinic that are on everolimus for large AMLs that have avoided other intervention. I'm going to get to that later. So I want to go over a little bit of the neuroimaging findings. These are the classic tumors that have been discussed, for which, as an oncologist, we don't make an intervention. But I've had at least 2 phone calls from smaller centers of kids who were not known to have TS, who had MRIs for some reason that had TS, and it was based on these lesions. And the families are actually, one of the families was told that their kid had metastatic cancer, which is kind of unfortunate, but it is what it is. And then there are subependymal nodules, which on CAT scan you see these calcified lesions that are small in the ventricles, and then on T2 weighted MRIs, the calcified lesions are actually black, so you see those there. And then what I typically get involved with is helping manage the patients with subependymal giant cell astrocytomas that are seen here pretty obviously within the ventricles, one unilateral, and this here crossing both sides. And this is how I had the honor of meeting Daniela and her family. So Sega may be a misnomer. The World Health Organization describes these as benign tumors of glioneuronal origin that are distinct from astrocytomas. So even though the word astrocytoma is in the name Sega, it's not classically histologically an astrocytoma. And these are seen in around 15% of kids with TS. And they usually develop in childhood and adolescence. And if you don't have one by the time you're 25 and you have TS, you're probably clear and won't have to deal with that going forward in the future. The They're usually in the anterior portion of the lateral ventricles, and they can be very slow growing, but they can affect CSF flow, which therefore can cause a really big problem with increased intracranial pressure and obstructive hydrocephalus. And the patients can present with headache, vomiting, unsteady gait, sometimes change in seizure frequency, change in vision, and behavioral changes. And the goal is, what can we do to intervene sooner instead of wait for those things to happen? So as a fellow, 15 years ago, basically for Segas, they were just observed, and if they were amenable to surgery, they were surgery. And of course, now we have the option of mTOR inhibitors. So great time for me to volunteer to give this talk, because this year alone, there's been some really fantastic review papers, both on the imaging and the management and natural history of these diseases. And this takes us through a really nice algorithm of how to intervene. And I'm not going to go through the whole puzzle, but it's just to say that in general, for patients who have a very small Sega, surgeons feel they can get to it and it's on one side. Probably the easiest thing is just to take it out. For patients who've had recurrent disease, or the surgeons can't take it out, or if it's bilateral, then those are the patients that we're looking to use mTOR inhibitors more often. And I just call your attention to this part where we have the patients on mTOR inhibitors. I think the big question that we're having now is, so after a period of time that you're on your mTOR inhibitor at good levels and you have a response and things are stable or shrinking, how long do you continue? How long do you tolerate the side effects from it? Some of our patients have pretty bad mouth sores on it. There are other side effects. And how should we go long term? And do we really know the answer to that question yet? And my understanding is conversations between Fatima and other colleagues here is that there are different ways to approach this. So I want to go over another publication just from this past summer over the long-term use of everolimus in patients with TS vis-a-vis some of the tumors that I just discussed very briefly. And this was a randomized controlled placebo study of everolimus versus placebo in patients. And just looking at some of the outcome data, it's really remarkable if you look at the mean reduction in Sega and renal AMLs over time, over 240 months. Here we see the Segas, so decrease of 30 to 40-ish% in the Segas, and even greater in the AMLs based on prolonged mTOR inhibitor use. And keep in mind, especially for the fellows and the postdocs in the room, when I was a resident, we had nothing. So to go from 25 years to now, standard of care is a medicine that was discovered in the lab and truly brought from bench to bedside in that period of time. It's really remarkable. And I remember Nico around 10 years ago begging me to start rapamycin in one of the patients. I'm like, I'm not doing that based on some lab paper. You're insane. That may have been what I said to my chief, not to your face, but then when David Franz came and spoke to us about it and showed some early clinical trial data, it was so compelling. It was a really exciting time to be part and involved in these patients. And Danielle is that story. The surgeons had done everything they could for her and said, we are afraid we're going to hurt her if we do more surgery. And I'm pretty sure she was not interested in more surgery at the time either. To the point where she's like, no matter what you say, I'm not getting more surgery. So to be able to start a novel medicine and then see over several years, the benefit has been just fantastic as a clinician. This is just another result from that paper looking at the proportion of patients that had more than 50% reduction. Again, Segas and the diamonds up here, and the squares, the AMLs. So really demonstrating prolonged clinical efficacy. But like most things, it's not without toxicity. So there's some serious side effects that really are troubling to some patients. 2 of our patients have really bad stomatitis, really bad mouth sores. And I think that we're managing levels where I'll think about stopping or give holidays. But we have to, as clinicians, have a better understanding of, for the patients who are having side effects, what's the prolonged course? How do we have to manage these patients going long term? All right. I wanted to, there's been a lot of shout outs to folks. I did want to talk about some of our other clinical partners, at least very briefly, and then some of the imaging partners very, very briefly. So these slides are courtesy of Rick Abbott, who co-directs the neuro-oncology program in pediatrics from the neurosurgical perspective. And I'm not going to go through his fancy pictures, but I just want to highlight the importance of having someone who has specific interest in pediatric neuro-oncology as a surgeon. There are a number of phenomenal neurosurgeons and phenomenal oncologic neurosurgeons, but you really need someone with dedicated interest in pediatrics to understand the diseases that we take care of and what we need to do for our patients and have experience in those specific domains. I also wanted to thank Mark Waxel because he's been recently a really nice partner with some exciting imaging techniques. I'm hoping that he'll be there this afternoon and we can talk about this, but this is some of his work looking at elastography. And one of our prior speakers spoke about the perilesional changes next to the tumors that you might not see with conventional MRI. And I think Mark is finding ways to look at focal cortical dysplasia and these perilesional areas with elastography, which I apologize in advance, but basically they put points on the zygomatic arch, and they shake the patient's head very, very narrow frequency, and that helps them measure the elasticity of the brain, and different images can compare the practical imaging or the conventional imaging to the elastography, and may give us clues for our surgeons where they might want to see a target for epilepsy surgery, or for me as a tumor person, where that might be evidence of tumor beyond what we're seeing on the conventional MRI. So there's a grant that Mark has put forward that we're part of, and hopefully we'll get to do more work in that regard. And then I also want to give a shout out briefly to Bill Gomes and other colleagues in imaging, neuroradiology. This is not a patient with TS, but it's just an example of tractography where Bill helps our surgeons really look like, what do I need to avoid? Like, this is safe, nothing's going through it, but this is the tract of that neural fibers that you kind of really make sure. And again, just pretty novel imaging techniques that help our surgeons do the job we do, which speaks to having a critical mass of folks that are intimately interested in one discipline, not just kind of catch as catch can at the same center. So with that, and trying to get us back on time, I want to thank you, and in particular Fatima and other colleagues for collaborating together. So thanks so much.
Adam, thank you very much. Questions? We have time for maybe one.
Actually, just a comment real quick. That was a great talk. Can you go back to your slide showing the side effects?
Sure.
Yeah, it's just important to point out, if you look over time, the incidence of side effects across most of the domains diminishes pretty dramatically. So while it's pretty harsh early on going in terms of stomatitis and other side effects, if you follow out over time to people who are on for greater than 48 months, the incidence of side effects does indeed fall off. And I mean, that's been my clinical experience. I don't know if that's your clinical experience or Mike, but over time, people tend to tolerate it better.
Yeah, so I totally agree. Unfortunately, one very special person in the room is in this category where she's still having, over time, the problems. And yeah, absolutely. Listen, compared to typical chemotherapeutics that I give every day, this chart is not at all daunting. But, the goal is, as minimal side effects as possible, especially for something that we're giving for such a prolonged time. But yeah, definitely appreciate the comment. Thank you.